According to G. Hirsch and B. Wagner, idiopathic toe walking is a diagnosis of exclusion that is arrived at when there are no signs of neurological, orthopedic, psychiatric, or pediatric disease causing the symptom. Developmental delays or prematurity of birth can also be the cause of toe walking. Muscular weakness and shortened gastrocnemius muscle length are two more causes of toe walking, according to G. Hirsch and B. Wagner. The toe walking pattern will resolve spontaneously in a majority of children. However, the natural resolution of the toe walking problem could take years, which would limit the child's development greatly. Whether surgery is indicated or conservative treatment is being implemented, the main goal of any treatment is to increase dorsiflexion range of motion to 10 degrees for tibial progression in order to ambulate with proper heel-to-toe gait pattern. Although it is typically avoided, indicated surgery is only successful 63% of the time. This case study was done to describe development and implementation of a multifocal conservative treatment for toe walkers. A 3-year-old boy presented with toe walking. After 3 months of physical therapy, his gait had improved and physical therapy was stopped. The same boy, at 7.5 years of age, presented with reoccurring toe walking, sensory aversion on hands and feet, decreased ankle dorsiflexion, and absent heel-to-toe gait pattern. Conservative treatment began and lasted for 35 weeks. Physical therapy involved stretching, strengthening, neuromuscular re-education, functional activities, and desensitization techniques. Stretching exercises were performed in order to lengthen the gastrocnemius and soleus muscles, and were performed daily with 30-second holds for 3 repetitions. Strengthening exercises were also aimed at the gastrocnemius and soleus muscles, as well as general strengthening of the lower extremity, and were performed 3 times a week for 2 sets of 15 repetitions. Desensitization exercises were to help the patient feel more comfortable with varying textures on the heels. The neuromuscular and functional activities were performed together in order to retain the motor program and develop a more efficient and correct motor program. During the initial evaluation, the goals were set. Increase bilateral dorsiflexion to neutral, increase bilateral hamstring to 10 degrees, ambulate 30 feet with 2 arm swings and flat feet on 3 of 3 trials, running with heel contact 90% of the steps taken, and squat while maintaining heel contact on 8 of 10 trials. The patient was seen 2 times a week for 16 weeks for 60 minutes, and then was decreased from there. After 35 weeks of physical therapy, the outcome was noticeable. The patient had improved dorsiflexion. Range of motion increased from -6 degrees to 7 degrees on the left side, and -10 degrees to 0 degrees on the right side. The patient was also able to ambulate with heel contact 100% of the time. The outcomes from this case suggest that conservative physical therapy can increase range of motion, improve gait pattern, and avoid surgery for toe walkers.